Hi. So today I'm going to talk about eating disorders and then a very brief piece on somatic disorders. So it's the last lecture that I'll do online for you, and it completes the content of the course. So we're getting through this, thank goodness. You only have a little while longer and you'll be getting ready to end the semester. So eating disorders, very complex, interesting kind of phenomenon or illness. Um, we hear a lot about people with eating disorders, and how can that be? I mean, I think it's probably one of the most perplexing of the disorders that we talk about in mental illness. I'm just following along your PowerPoint. So while you're listening to this, if you want to pull that up, might be helpful. So question is, who would starve themselves? I mean, most of us struggle with um, liking certain foods and we can never get enough of them, or we have some hunger and can't wait to eat. It's fun to sit and have a meal with friends. Have a meal on the go when you're really hungry and you've got to go to your next class or whatever. We all have patterns of eating. Some people skip breakfast, which I understand is not a healthy way to, especially if you want to maintain your weight or lose weight. But some others of us have a pretty standard routine for breakfast and lunch, and maybe vary our dinner or after dinner snack before bedtime. So again, why would someone want to make themselves vomit and or have diarrhea, use laxatives to get rid of anything that we've eaten? And the other piece is in terms of anorexia nervosa, not even having the sensation of wanting to eat. So I'm first going to talk about anorexia nervosa and the characteristics of this eating disorder. So it's marked by a refusal to maintain normal weight for height, and that person has an intense fear of gaining weight. I mean, it really is very remarkable and intense. It makes behavior what it is in terms of anorexia, this intense fear of gaining weight. People who have anorexia nervosa see themselves as fat, and they will avoid putting on any extra ounce or fat onto their body. So there's a piece of them that tries to maintain that light weight. It's a fixed belief, and although we don't consider it a delusion or psychosis, but it's so ingrained and so part of the illness where that person truly doesn't see what they look like in terms of a normal height and weight, but instead sees themselves as fat. And they will talk about that. That intense fear keeps them from being able to follow any treatment regimen that's required for anorexia. The piece about this illness is that it can become a medical emergency with serious physical consequences, medical consequences, and can lead to death. We're designed to add food and fuel to our daily life to balance our electrolytes, balance our fluid intake and output, and it's part of what keeps us alive and healthy as we navigate our lives. So then there's another eating disorder called bulimia nervosa. And this illness actually includes binging on food. Um, but once that person binges, they want to get rid of that food that they've taken in, which is in excess. So, similar to persons with anorexia, they'll use vomiting, they'll misuse laxatives, they'll use diuretics, excessive exercise. All of those pieces can also describe anorexia nervosa. This eating disorder is primarily focused on overeating and binging. Um, this illness is a little bit harder to detect. Most of the time, people with this illness might appear a little overweight. They don't look real thin and gaunt and kind of having that prisoner of war look that we saw so much in World War II with the concentration camps. Um, Physical dangers similar to anorexia, electrolyte imbalance, cardiac arrhythmias, dysrhythmias. Another of the eating disorders is called binge eating disorder. Um, this person engages in repeated episodes of binging large amounts of food at one time. Um, Often alone and often at night. There's a propensity to binge at night. You may know some people that do this. Just have dinner and then, as the evening wears on, just eats and eats and eats and snacks on snack food, ice cream, all the different pleasurable foods. Um, I had a client who had this, and again, people that have these illnesses, first of all, there probably is some shame and guilt and secrecy. I mean, this is pretty secret that they do this. But I had a client who was, to me, she was depressed, and she would go to the ER several times a week with gastric problems and feeling really sick. And it took a long time for me to discover, well, what happens to you during the evening? Because she said she'd go along, and then towards evening, she would begin to feel ill. Well, eventually she was able to disclose that she would have dinner and then she would binge eat, and would get to the point of being so uncomfortable. She would actually sit in a hot shower for 2 hours at a time, trying to manage the pain she was in. When eventually it became too much and her GI system probably was exhausted from all of this, and she had some serious GI symptoms, um, and refused to really acknowledge that this was a disorder or illness, and also really struggled with admitting that she was depressed. And of course, that was our focus of treatment, was her depression, and then hopefully getting her to look at how she was eating. So binge eating disorder, gastrointestinal distress is a hallmark, esophageal, painful stomach, bloat, intestinal dilation, and secondary health problems. So you can imagine with anything in excess going through the GI system over and over and over again, the kind of medical problems that would ensue. People with these kinds of eating disorders won't seek treatment. And again, the reason my client went to the ER frequently was she was in so much pain. And again, characterized by shame, guilt, and absolutely hide this behavior from others. Sorry, I can't sort of pull this up. Um, there's going to talk a minute about the etiology of eating disorders, and there's a uh, video at the end. Laura Hill talks about eating disorders and talks about the brain, the amygdala, the prefrontal cortex, um, fMRIs showing what happens for someone who has anorexia. She actually talks mostly about anorexia in this film. But I think you'll find it pretty enlightening. And it talks about that biologic and neurobiologic relationship within the brain with the sensations of the pleasure of food, being hungry, enjoying the flavor of food, and eating as a pretty normal activity that we all um, need to engage in order to stay well and continue on. So they're not quite sure causatively in terms of genetics. The research so far is fairly strong in terms of genetic. And, I wrote this a couple of years ago, so there may be more now written about this. And in terms of genomes, I mean, we're absolutely looking at different illnesses and where that fits in with genomics. Neurobiologically, absolutely, we think there's an alteration in serotonin. And as I mentioned before, Laurel Hill talks about the amygdala, the prefrontal cortex, absolutely interferes with one's ability to enjoy the taste of food, and also is responsible for that person not having a sense of hunger and wanting to eat. Psychologically, that person can feel overwhelmed and feel powerless. And a lot of times, especially with anorexia nervosa and bulimia nervosa, there is a sense of power that that person has over their body and over what they'll take into their body. So there can be a real struggle in terms of power. And we see that a lot in terms of when we work with people with different eating disorders. It's a real sense for them about wanting to maintain power over their decision making and their eating and what they'll eat and when they'll eat, and so on and so on. There's a sense that it could be a learned behavior. Person loses weight, looks good, there's some real affirmation, how beautiful they look and desirable they are. You can imagine, particularly among preteens and teens, young adults who awake and somehow are feeling more attractive than ever after losing weight. So there's some of that um, reward, positive reinforcement of not eating. I've also become aware over the past several years of there being websites devoted to how to become anorexic, how to engage in eating habits that lead to anorexia nervosa. And culturally, how we value people that are very, very slim, um, have no extra body fat, and have a particular look. I mean, any of us that follow sports, follow people that are celebrities, we're all aware of how people struggle with their weight and will actually work hard to not eat. Um, so, I did meet a few people in my practice, interestingly, people who had, the weight reduction surgery, the gastric bypass surgery, and would begin to lose weight, felt really good about themselves eventually, because there is a big piece around accepting your new body and the way you are, but eventually would get to the place where, wow, they just were really feeling great about being so much thinner. And then where would that cutoff be? Just a few people I knew or I worked with would actually, we'd have to encourage them that they need to eat. They can't keep losing more and more weight. And again, culturally, our culture reinforces thinness. Eating disorder comorbidity, well, you can just imagine anxiety, obsessive compulsive disorder, depression. People you probably know, sense from yourself or people you've known that have been depressed that, appetite is waning. People will a lot of times lose weight. Some of the other comorbidities, behavioral disorders occurring in childhood. They think that there might be some linkage there. Oppositional defiant disorder may go along with person having that may go along with not eating. Personality disorders, sometimes people with borderline personality disorders also have eating disorders, and histrionic personality disorders can also accompany anorexia nervosa, bulimia nervosa. All right, so probably one of the most serious of the eating disorders is anorexia nervosa. So again, people don't willingly go into treatment who have anorexia nervosa. Again, they see themselves as fat. They're working hard not to gain any weight. They have a kind of a secretive lifestyle in terms of what they eat, or they might be over exercising, so on and so on. So usually when we see someone in the hospital, they're in acute distress. It may be critical at that point, related to purposeful starvation. And even using that term, it's a little, I don't know, it's a little contradictory because, we are looking at an illness of the brain and brain function. But where does that begin? There's talk about, again, powerlessness, and a lot of times within the family dynamic, that person exerts some power over, come on, you need to eat. No, I'm not hungry. Come on, you're getting too thin. No, I'm not eating. I'm not going to eat. I'll have something later. And again, that person might decide exactly what they're going to eat. Maybe a few crackers, maybe some cottage cheese, but certainly nothing that they can um, maintain their health with. So really important to look at your own sense of how you feel about people who won't eat. It's tricky because it's always like, I can't believe that person won't eat. Look at them. They're all bone. Their face is all sunken in. They look like, they've been in a prisoner of war camp. Certainly can't look that attractive. And so we can be very judging and very critical of someone who won't eat. And really lose our patience with them. I mean, truly, they're some of the most difficult people to treat. So we have to be careful. We can't really comment on their looks. We can't really comment on their weight. And we have to remain non-judging. And in fact, there are specialty services. For example, there is a eating disorder. I think it's outpatient now. It used to be inpatient, but I'm not quite sure. But was part of Mercy Hospital, and it might be a more independent treatment group now, but was in Portland, and certainly looking at how we could be so judging of people and how they absolutely need specific treatment. So multiple assessments you would do just because you know what you need to do. Safety, client's perception of themselves, their eating habits, their dieting history, methods of weight control, interpersonal issues. Again, a lot of times there's issues within the family. There can be issues of power and power struggles within the family. Social functioning, mental status, and so on and so on. So you would do a real complete assessment on someone who has anorexia nervosa. So what are some of the physical signs and symptoms? Um, so one of the markers that's put out there is weight loss of over 30% of their weight within a 6-month period. And also a rapid decline in weight. When you're working with someone, they're depressed, they come back in, their depression has deepened, and you notice they've lost a lot of weight. So red flag, you would be concerned about what their eating looks like now, and especially as they get better, do they continue to lose weight? And are you then concerned that they might have an eating disorder? Severe hypothermia is another symptom of anorexia nervosa. A temperature lower than 36 degrees Celsius or lower than 96.8 Fahrenheit. And just physiologically, there's a loss of fat tissue, a loss of insulation, so to speak. Dehydration, absolutely. And you probably would note this in their electrolytes, their intake and output, specific gravity of their urine, all those markers that indicate they're dehydrated. Their heart rate can be less than 40 beats per minute, which, I mean, if you're taking care of somebody in the hospital and their pulse dropped to less than 40 a minute, you'd be like frantic. Oh my God, something's going on here. Systolic blood pressure, less than 70 millimeters. They can absolutely have hypokalemia, less than 3 milliequivalents per liter, or other electrolyte disturbances, and absolutely EKG changes, arrhythmias, having to do, of course, with the electrolyte and fluid balance in the body. Physical signs and symptoms. They can appear ill. I mean, you don't look at them and think, wow, isn't she attractive? Very robust, looks like they have a happy life, looks like they take good care of themselves. I mean, people look ill. They look undernourished, malnourished, sunken eyes, head looks out of proportion to their body because of their loss of body tissue. Again, they can be remarkable looking. I know going to some of the exercise clubs or fitness centers, I would be aware of someone who was there a lot and would be working out for quite a while at a time, and they look like they had no extra body fat. So people typically wouldn't eat and also would over-exercise. And sometimes you see them at your own fitness center or some other exercise places. Lanugo, now that's an interesting term, and a lot of times I'll ask students what that is. So it's integumentary, it's having to do with the skin and hair. And lanugo is kind of downy type hair that can grow all over the body for someone who has anorexia nervosa. It's pretty remarkable. It's similar to, a newborn's hair that's kind of fluffy and thin and has kind of a cottony feeling to it, kind of wispy. and that person will have lanugo over their body. Oftentimes they're very pale looking. Amenorrhea for women is a big marker of having anorexia nervosa. Impaired hepatic function, jaundice, gastrointestinal, you can just imagine constipation, abnormal lab values, vitamin deficiencies. So anything that has to do with how we nourish ourselves with food, you're looking at a real deficit and pretty remarkable and dramatic change. Cardiac, you're looking at hypertension, bradycardia, heart failure, cold extremities, peripheral edema, so that the circulatory system is absolutely impacted. And peripheral edema, from adult health, when there's a deficit in cardiac circulatory systems, that peripheral edema can absolutely be there. Renal, again, impaired renal function, acute chronic renal failure, and hypokalemia. Hematological anemia, absolutely. Pancytopenia, decrease in all 3 blood cell types, is also a marker of anorexia nervosa. And musculoskeletal, decreased bone density, muscle weakening, and a wasting. And again, hate to bring you back to this, but people were studied post the concentration camps where they absolutely suffered from poor nutrition and almost no nutrition, and how they could look and how muscle wasting and decreased bone density occurred, and most likely bone fracture. So again, in anorexia nervosa, medical complications are many, and consider the effects of starvation. So really you would, any way you want to look at it, if you realize the effects of starvation physiologically in the body, you'll be very aware of signs and symptoms. Psychological signs and symptoms, suicidal, absolutely very common. And in fact, when people who are part or have this illness, if they are in conflict with others over them being made to eat, them being force feeding in the hospital, absolutely can be quite suicidal. And you figure too, in terms of depression, certainly can be very depressed and suicidal. Self-mutilating can be a symptom psychologically. Out of control use of laxatives, emetics, Ipecac, diuretics, prescription drugs, street drugs, alcohol, depressed, psychotic, family dysfunction. Now, I think the psychosis would absolutely come with poor nutrition, certainly of the brain, and in terms of the functions of the brain, that so many things can interrupt our sense of reality. So people can absolutely become psychotic. And again, the delusion around I look fat, I'm not quite sure that fits into psychosis. If you think about some of the anxiety disorders, in terms of like looking at my face and it's not symmetric, and I'm really homely, and I need to have my eyebrows changed or my nose fixed or whatever, that can certainly be a symptom of an anxiety disorder. So not quite sure in terms of seeing that I'm fat, and in fact it's not true, but certainly can be so close to being delusional about the way they're thinking and seeing. So continuing nursing assessment, psychological signs and symptoms, self is fat, self-worth by weight, terrified of gaining weight, real terror of gaining weight, self-induced vomiting, preoccupation, thoughts of food, peculiar handling of food. Now, if you were working with someone in the hospital, you would note that they push their food around, they might be hiding food, um, yeah, they might, drop food on the floor, try to somehow make it look like they've been eating, but just some kind of peculiar things that you'll notice when they're eating. Development of rigorous exercise regimens, and certainly disturbed cognition just from the fact that they're not getting proper nutrients to the brain. Nursing diagnosis, tons of them. Imbalanced nutrition, less than required, decreased cardiac output, impaired tissue perfusion, risk for injury, electrolyte imbalance, imbalanced fluid volume, psychological, psychiatric, disturbed body image, ineffective coping, and chronic low esteem, self-esteem. I mean, even though they might be very, very thin and still see themselves as fat, it does affect their sense of self-esteem. And they don't necessarily feel good about the way they look. So the goals, safety, and that's certainly global in terms of psychological and physiological, attainment of a safe weight, and that is a major hurdle for persons with anorexia nervosa. It's the goal of treatment. However, it's very, very, very difficult. Sustained weight and understanding of the underlying cause of anorexia nervosa. I'm just going to pause for 1 minute. Okay, so I'm going to talk about anorexia nervosa and immediate attention. So it's hospitalization for extreme electrolyte imbalance or weighs below 75% of the recommended body weight. Cardiac, renal, or hepatic dysfunction. Then there's a piece called refeeding syndrome, and it's interesting, and have you kind of pause and think about this, that someone hasn't been eating and eating well for a long time. And so, of course, we are concerned about, well, let's get them to eat. However, there's a real serious complication of, we call it refeeding that person. And it was discovered, I know I keep referring to World War II, but we learn a lot about being at war, and unfortunately how people respond and some of the side effects of war. So this involved starting that person back on a therapeutic nutrition. So what can happen with that? And you can just imagine intracellular and throughout the organ system of the body. So returning to beware of refeeding syndrome. So serious complications can result if refeeding isn't done slowly and carefully. Shifts in fluids intercellularly, intracellularly, serum electrolyte shifts, cardiac dysrhythmias, sodium retention, and death. And again, this was all discovered after people were held and not fed for such a long time or underfed. So then once medically stable, if they are admitted in this acute situation, once they're medically stable, certainly inpatient and outpatient programs. And various, I've got down here, various intensive psychotherapies for client and the family family has to be involved. I mean, that person lives within a family, unit, and most likely isn't living with friends at that point because they're deathly ill. So the family really needs to be part of the treatment. And again, a lot of times it's so difficult because there's such a power struggle within that family, similar to family in terms of that person struggling with substance abuse or addiction, where there needs to be an important balance in terms of being supportive, and not enabling or not getting into these huge conflicts where that person is like, absolutely, I'm not eating, see if you can make me do that. So very, very difficult illness. So what are some of the nursing interventions then? And I'm not quite sure you'll see this in your practice. Certainly if that person is critically ill, you might see them on a medical unit. But many times persons who have this illness are treated in particular treatment centers, because of the very nature of dealing with all the different symptoms and psychological ramifications. So if you are, or you're working with someone who has a history of anorexia nervosa, non-judging, and it's tough, because right away you want people to eat, you want them to be healthy, you want to encourage them to have a balanced diet. I mean, and balanced nutrition. I mean, how many times do we make that part of our care in terms of people and what they're eating? Support their feelings. A lot of times people don't say a lot. People can be pretty shut off from feelings. So underlying emotions, be aware of those. Interventions in terms of depression or anxiety, you certainly want to be aware of that and help them with some considerations around depression or anxiety. Pharmacologically, SSRIs, boy, you just have to think about how many times we recommend SSRIs. So absolutely, we're looking at serotonin, the neurotransmitter. Fluoxetine is the drug of choice, and I'm sure other SSRIs are also used in terms of increasing the amount of serotonin available. And I've got a note here that fluoxetine also helps with obsessive compulsive tendencies. So, there's this piece. I mean, it's so interesting because it's on the edge of so many different disorders, but it has to do with eating, has to do with our ability to feed and nourish ourselves. Olanzapine is an atypical antipsychotic, helps with additional mood stabilization. And there's some thought that it can actually increase appetite. Now, again, here's an antipsychotic, and you just have to wonder what kind of effect might that have on some delusional piece around the way people see themselves. Health teaching and health promotion, self-care, coping skills, problem solving, decision making. I mean, you're really talking about someone who is not deathly ill at the time and also is willing to go through treatment, and you can imagine if someone has shame and guilt or is hiding all this, although it's really hard to hide the fact that you're so malnourished, how likely are you to want to stay in treatment? So that was always a big piece. I know when I worked at St. Mary's on their psychiatric unit, we would occasionally get someone with anorexia nervosa. I never felt skilled in that area, because refeeding takes a certain technique, certain protocol, and also working with someone who really is refusing to feed themselves, to give themselves what they need nutritionally. Family support, self-help groups, family therapy, psychotherapy, and again, how willing are people to be in treatment. Teamwork in the unit, treatment planning, close collaboration. If someone, now I do remember someone being at Spring Harbor Hospital while I was a nurse there, and the person had bulimia nervosa. And so we had to really have particular protocols, especially after eating, and then making sure that they didn't go purge. And so if they needed to use the bathroom, we would go to the bathroom with them. We watched them. If they're moving food around their plate, we would notice that. We would make sure that person wasn't hiding food or getting rid of food. So there's real particular protocols. And I think that I'm not sure you would see this in, a general practice, but that you would see it more on a specialty unit or outpatient program. Close collaboration, management, manipulation. That person will want to go and purge. Absolutely. That's what they want to do right away. It's almost like, they've been poisoned and they want to go get rid of this as fast as they can. Highly structured units, precise meal times, adherence to menus. Observation during and after meals, 1 hour after meal, in the bathroom, and after visitors. Visitors may bring laxative in or Ipecac or whatever for that person to be able to rid themselves of whatever they have eaten. Early AM weekly back to scale weight in the same Johnny clothing, check pockets for money, NPO until weighed, and then advanced practice intervention, individual, group, family therapy, and med management. So that's kind of it for anorexia nervosa in terms of assessment and treatment. Now I'm going to go back to bulimia nervosa. Now again, physical signs and symptoms. People may not look ill. It's like you don't really have a clue until you get to know that person or watch them a little more carefully. So people can look normal in terms of weight or slightly low weight. And it may even fluctuate. You might see it like, wow, and then get overweight again and then lose weight. And, you just have to wonder, what are people doing with food? What are they doing with food, and what are they doing with exercise and or laxatives, emetics? Now, this is a real telling sign. Their knuckles are calloused, they're bruised, and then they are calloused. They can have scars on their hands. That's called Russell sign. And all of this comes from induced vomiting. So that person is in the habit or uses their fingers, their hand to induce vomiting at the back of their throat. So you'll see that. You'll see some scars, or you'll notice some different kind of coloring on their hands or knuckles. Enlarged parotid glands are another symptom, and those are located in the throat area, and they would become enlarged because of the constant purging. Dental erosion, dental caries, because again, the gastric juices come and they're very acidic and wearing, and they can have an effect on the enamel of the teeth and also cause dental caries. Self-gastric dilation, esophageal injury, tears, and ruptures. So it's quite devastating to that whole upper GI system when someone is continually vomiting and purging and using emetics. And of course, using laxatives, there can be terrible inflammation of the lower GI system and everything that goes along with having some diarrhea. So similar to anorexia nervosa, bulimia nervosa has critical medical issues similar to anorexia. There's many medical complications. So once again, you can imagine there's a binging. That's the big thing about bulimia nervosa, is there's a binging of food and then getting rid of that food. So bradycardia, cardiac arrest from electrolyte imbalances, ipecac intoxication, mitral valve prolapse, dehydration, esophageal tears due to induced vomiting, and severe abdominal pain, which I mentioned before about my client, electrolyte imbalances, hypochloremia, and hypokalemia are some of the noted electrolyte imbalances. So nursing diagnosis, bulimia nervosa. It looks a little bit different from anorexia in that it's more than required. So it's imbalanced nutrition more than required. Decreased cardiac output, impaired tissue perfusion, risk for injury, electrolyte imbalances, imbalanced fluid volume, ineffective tissue perfusion, psychologically, psychiatrically ineffective coping, chronic low self-esteem, powerlessness, and again, chronic low self-esteem. I don't know why I have that in there twice. The goals, planning interventions, evaluations, very similar to anorexia nervosa in terms of what we would do in terms of interventions. So the next piece is binge eating, and let me just take a pause here. Thanks. So binge eating is another category of eating disorder. Doesn't usually require hospitalization, and of course there's always an outlier where it may. This is probably where my client fit into this. Doesn't usually require hospitalization, but there are physical signs and symptoms of this. Probably even more difficult to flush out, and the practitioner may not get a sense of this going on. I mean, that person really would need to somehow divulge that to you, and or you find out about it, or if they are with someone, the family member or friend or whoever has shown great concern for them. Excuse me. So physical signs and symptoms include eating larger, normal amounts of food during specific times. And again, I mentioned with this one particular woman I worked with, it would be after dinner. This would all happen. I mean, just kind of a moderate, balanced nutrition during the day. In fact, she had a job and she really liked her job, and she was in a relationship and really cared about her partner, but would have this kind of secretive life post dinner and later on into the evening. Creates obesity and other GI problems. Large amount of food dilates the whole GI tract, heartburn, dysphagia, bloating, abdominal pain, diarrhea, urgency, constipation, and a feeling of anal blockage. So any interruption of normal function of the lower intestine and intestinal tract and GI system would show up in terms of this person's complaints. And again, she did not make that connection between overeating and, bloating, extension, but would go to the ER with acute abdominal pain and would say, I don't know what's wrong with me. I need to find out what's wrong with me. And it's so frustrating because you want to point this out and you want to say, well, it sounds like you overeat at night and then you're in a great amount of distress. You can imagine, like, you go to the fair or you go to a big party and you overeat. There's something there you love and you just eat and eat and eat. And later it's like, oh my God, why did I eat so much? I mean, there's holidays we typically can do that around. So this is happening on a daily basis. Again, difficult to diagnose if obese, eating more calories, food required, or are they having binge periods of eating? So it's really hard to diagnose this. Assessment, thorough exam and blood work, thyroid, CBC, other medical conditions may be present. Comorbidity in terms of psychiatric diagnoses. The client I worked with absolutely had depression and eventually had a lot of interpersonal relationship issues. Her partner eventually left, couldn't tolerate what was happening. She became more and more symptomatic. And really questioning, everything that she was doing and everything happening in her life. So wasn't real stable in terms of her psyche and her sense of self. History of binging triggers, food frequency, sometimes difficult to obtain this kind of history because, again, the client can have tremendous shame and guilt and secrecy. And for this person, I mean, there was almost this kind of delusional piece where she was not making connections between what was happening for herself every evening, every night, and the amount of GI pain she was experiencing. That person's self-esteem is overly influenced by their physical appearance. And this particular binge eating has a more difficult recovery period. And in fact, probably even treatment resistant, where that person is not going to tell you what they're doing with food. So again, nursing diagnoses are similar to anorexia nervosa, bulimia nervosa, imbalanced nutrition, more than body requirements, disturbed body image, ineffective coping, anxiety, chronic low self-esteem, powerlessness, and social isolation. I mean, you figure someone is binging at night and then causing themselves to lose all that food and fluid. They're not engaged in a normal relationship in the evening or whatever. I can imagine a lot of different pieces being affected. So outcomes that you want in terms of working with someone who binge eats, nutrient intake meets metabolic needs. That person does become satisfied with their appearance, their body, somehow develop some effective coping skills, decreased stress, maybe finally able to use a support system, shows increasing confidence in making decisions, willing to call others for support, assistant feels a sense of belonging and no longer isolating. That is huge. I've worked with people who have gone, and I mention it here in the slides, to Overeaters Anonymous, which is a very important self-help group that helps people avoid overeating. And people will oftentimes tell you what their triggers are and what foods are triggers. A lot of times it's bread, carbohydrates in the form of bread and flour and yeast and so on. Some people, it can be sweets, but boy, bread was a lot of it. And then, now that I think of it, I had another lady, and she would eat bags of candy, and then hide the bags. I mean, she lived alone, but she was still hiding them everywhere. It's part of that whole secrecy thing. You don't want anyone to find out. And she would binge on candy at night. So her triggers were emotional, and then also she loved to eat candy. So nursing interventions in terms of binge eating, mostly done on an outpatient basis. And I have a piece here, unless they're hospitalized for a co-occurring condition. And maybe you're working with someone who's depressed or have some other psychiatric issue, and you're also noting that people are bringing stuff in for them to eat, they're requesting certain things, and you're noticing that they eat a lot of that particular kind of food. So again, they're not going to tell you. So much shame and guilt, they're not going to let you know. So advanced practice, one-to-one psychotherapy, CBT, it would be looking at the way we think about ourselves. Where did we get these thoughts that we have about who we are and what we do? So we would use CBT to try to unravel, where did those thoughts come from? How true are they? What if you can replace those kinds of thoughts with another way of thinking? Health teaching, a lot of consequences about binge eating, and mostly people recognize that, and it would sort of go like, well, I don't understand it. I've tried dieting and such and such and such and such, and I never lose weight, and I'm just getting heavier. And, and you just kind of sit with people like that, or people saying that. I don't mean people like that, but people saying that, and it's like, wow, well, I wonder what kind of diet you're using. And a lot of times it's right there in front of us that that person really is struggling with not eating certain foods, probably higher in calorie foods. Encourage expression of feelings and thoughts. And of course, that goes along with everything that you and I do in terms of mental health treatment and mental wellness. Okay, so pharmacological interventions. And this would be FDA approved for obesity and weight loss. I've got a few down here. Lorcaserin, Belviq XR, and apparently makes a person feel fuller by activating serotonin 2C receptors in the brain. So there you go. Here we are. We're looking at the brain, and there's some malfunction in the brain and the neurotransmitters. And I think you'll like the film by Laura Hill. She really does make some nice connections in terms of anorexia nervosa. Phentermine topiramate, a bi-drug compound, gives that person a feeling of fullness. Taste sensation is reduced, and is a quicker calorie burning, has a quicker calorie burning effect for that person. And then phentermine is the other part of this drug, Kiesmia, and it's an appetite suppressant. So topiramate is another part of that phentermine, topiramate. So I don't really know much about treating people with that. I've not really had any experience using those medications. And again, somebody has to be willing to take them and substitute following treatment for binging on some of their favorite foods. Teamwork and safety, absolutely. And again, not going to be coming in for hospitalization unless something really is quite traumatic about what's happening. They might come in for other reasons. Maybe they're suicidal. Maybe it's a breakup in a relationship and they're blaming the way they look, or they're heavy, or they're overweight, or whatever. And we're not just talking about women here, too. I just meant to mention that. We're not just talking about women. In fact, maybe for men, it doesn't always get reported that men are involved in some of these eating disorders, or have some of these eating disorders. All right, so then there's just a quick review of feeding and elimination situations in children. Pica, I'm sure you're going to talk about that with Professor Day, eating of non-food items. Kids will eat different pieces, different kind of pieces of whatever's lying around. And it doesn't make any sense as to what they're eating. You know, we are really worried about kids with pica who would eat paint chips in their apartments. And, you know, if you've worked with lower income folks or impoverished people, and they live in these old buildings that have lead paint, and the kids are peeling the paint off with their fingers and eating the paint, and suffer from lead poisoning. Rumination, and kids suffer from that. Regurgitation, rechewing, reswallowing, avoidant, restrictive of foods. Enuresis, involuntary or intentional voiding of urine into the clothes or bed twice a week, for at least 3 months. And encopresis, that would also really need to be investigated carefully. A behavioral disorder of involuntary or intentional inappropriate passing of feces. Occurs once a month for more than 1 month. And boy, I think if you're working with a kiddo who has encopresis, and or kiddo who's, you know, they're well past toddler age and they're having enuresis, you really want to consider if there's been some trauma there. So that can be a sure sign of trauma. So I just put that in because sometimes we used to do the Kaplan exams, and we would do the psychosocial Kaplans. They're a way of measuring, you know, your knowledge compared to other students, nursing students in the country. And there would always be a few pieces in there about kids. And I don't really teach mental health for children, but I would put this in just so that they would have that information. But I think that'll help you when you work with Professor Day next year. I'm sure she'll talk about a lot of those. So the next slide is the link to Laura Hill's TED Talk video. Boy, I think it might be like 40 minutes. I'm not quite sure. But for you to tune into it, you'll have to copy and paste and put that into your browser. I couldn't get it to hyperlink on this slideshow. So anyway, so this talks about calm, pleasure, satisfaction. is what most people experience after eating. So this is kind of like what Laura covers. But for people with eating disorders, food brings anxiety, disturbance, and she talks about noise. And she'll explain that and actually have you listen to what that noise sounds like for people who have an eating disorder. It's almost like, this background kind of um, noise that she'll have you experience. So she takes a look from the inside out, from the sound to the biology of these diseases, and how the future holds a different approach to manage the illnesses while helping these patients or clients have hope in their lives. So it's pretty interesting. I think you'll especially appreciate it because, you and I have talked over and over again about the brain and how it functions in terms of the different lobes, the structure, and also the neurobiology of the brain. All right, I'm just going to pause for a minute and then I'm just going to do a real quick piece on somatic disorders, just so you're aware of them. Okay, so as promised, I'm just going to do a quick chat about somatic symptom disorder. And this is only like 10 slides long. So, and make sure and review these for the case study and tests that I'll put together based on personality disorders, eating, and then somatic symptom disorder. So, somatic symptom disorder. The person reports physical symptoms, illness or injury, and it cannot be explained fully by a medical condition or direct effect of a substance. It's not attributable to another mental illness or disorder. And it is a maladaptive response to stress. So there you go. It's some kind of physical symptom or illness that that person is experiencing. So what happens then? Well, there's no significant physical findings or medical diagnosis that can be made. And this might be a person who keeps showing up in the ER like, dear, something's really wrong with my heart. I know it is, and so that person, they do a workup and nothing is found, and they'll do a follow-up and, are those symptoms still there for you? And nothing is found, not a trace. Now, the problem with this is there's a lot of people who absolutely have some defined diagnosis, something that is going on for them that can be substantiated. And a lot of times we just think, oh my God, here's that lady again. She's complaining about this or that, or, and we don't do a thorough inspection initially of what might be going on. So you gotta really be careful with this one. But this would be someone who consistently shows up. They have all these symptoms and ailments and complaints, and yet nothing over a period of time has been found that would explain these events. Their suffering is authentic. They are suffering. So not to make fun of them, not to belittle them, not to dislike them, although you might dislike them, but not hold it against them. That something is going on for them, and it's their suffering. This can appear during adolescence, and for the most part can occur before age 30. So people can have a long history of having this disorder. It's not to be confused with malingering or factitious disorders, where somebody deliberately makes up or exaggerates symptoms for what we call secondary gains, like to get your sympathy or your empathy or for you to feel sorry for them, or for them to get out of something, for them to not be able to participate in something. Something's going on. It's like calling in sick when you were in grammar school. Mom, I've got a terrible fever, and you get yourself up all worked up and tell your mom you have a fever and you can't go to school. So it's not like that. So characteristics, it's difficult in many aspects: social relationships, intimacy, parenting, education, occupational, and it's an impairment of high functioning. If somebody is so suffering from these ailments and illnesses as perceived by them, they're not going to be someone you can count on in terms of a work setting or school setting, or if you're trying to have a relationship with them. It really will get in the way. People who have this have high emergency room use and provider use. So they will call you and want to be seen frequently. And it's like, oh my God, Martha's on the phone again. She wants to come in and she says it's this. And, I keep saying, Martha, we've done all these tests and nothing comes back. And Martha still wants to come in. And can result in long-term disability related to that person being unable to keep a job. And so it sort of comes true for them. You know what I mean? It's like they're impaired and all this is going on, even though nothing is found biologically. And so what happens is they're impaired and they can no longer work. So it's kind of like it can all come true for them. They can be on disability. We used to call this hypochondriasis, a hypochondriac. We used to call it that. And now it's called somatic disorder, illness, anxiety disorder. I guess you could layer each of those over each other. So that person may be misinterpreting physical sensations. They're overly concerned with their health, very preoccupied with their symptoms, highly susceptible to suggestion. For example, books, magazines, internet symptoms, illness, disease research. It's kind of like when we all began studying nursing in the body and illnesses, and it's like, wow, I wonder if I have that. It's that whole thing. So this is it, 100% exaggerated. But kind of like, oh, gee, I wonder if it's, extreme worry, fear, may avoid seeking help or overseek health care related to fear and anxiety. And it has a chronicity to it and also can have periods of acuity. And I think you'll understand why in a minute. So definitions of somatic disorders, one of them is a conversion disorder, neurological symptoms, but absence of neurological diagnosis, presence of deficits in voluntary motor or sensory functions, sudden to gradual onset, and can be in response to a stressful event or situation. And then there's a piece called labile indifference, and they're not bothered or concerned about the symptoms versus expressing distress. So that's another kind of somatic disorder, which we would call conversion disorder. So definitions of somatic disorder, conversion disorder, some of the symptoms may be paralysis, blindness, movement and gait disorders, numbness, loss of vision, hearing, loss of hearing, episodes resembling epilepsy. Some of those symptoms can be evident. Comorbidity, you can just imagine, depression, anxiety, as with other mental illnesses. So what are the interventions that we look to assess for safety? Suicidal ideation. I mean, you know, you've always got to assess for safety. Any thoughts of hurting yourself? Do you get sick of this? Do you think about hurting yourself, or that you don't want to live, or think about killing yourself? Therapeutic relationship is very, very important. I mean, I worked with people with a number of these somatic disorders who would talk to me about things happening in their body that I didn't even identify what that was, but they would describe certain sensations in their body. And in order for me to work with them, I really had to develop a therapeutic relationship with them. I really had to look at what was underneath those symptoms. So therapeutic relationship, construct a mutually agreeable treatment plan, identify anxiety, and also help people learn some anxiety management techniques, and to avoid confronting the person about their symptoms and complaints. It will not help in any way to say, you know what, you're having a lot of anxiety, and so these things are a result of that. And you know, I think what we do is we try to get people to express feelings that they're having, because probably these symptoms are manifest of their underlying feelings. So we really try to encourage people to say, well, how are you feeling right now? What's going on for you right now in your life? And then nursing care interventions, specifically to continue with, encourage one-to-one therapy, educate them about expressing their feelings, and if that person has friends and family, to help them to encourage that person to express how are you feeling right now? I know you're complaining of this, but what's going on for you right now in terms of your feelings? Assist them identifying support systems. And then a big one that you can use with this, which is very powerful, is support the expression of feelings and through the arts. Expressive therapy is another kind of therapy that we use a lot, working with people who have a hard time expressing their feelings and putting words to their feelings. So the arts, writing, music, visual art, and journaling. And I did work, when I was at McGeechee, I did work with an expressive therapist on using art to express their feelings about being traumatized and or mistreated. And you can imagine where there aren't a lot of words to describe the horror of being abused. The art was very powerful. And the same for people with somatic syndrome, a lot of times not being able to put words to feelings and using the arts as an expression. Very, very powerful. You know, it's other than journaling, it's that use of nonverbal and how powerful that can be for all of us. So, all right, so that's it in terms of eating disorder and somatiform disorders. So I'm just going to take a break, and then I'm just going to say a few words about the next case study test. So I just want to talk briefly about the last case studies, tests for, that I'll give you next Wednesday. So you've got a little breathing room in here. So it'll cover personality disorders and eating disorders and somatic disorders. Couple of things of note. There's 2 films with the personality disorder excuse me a minute. Sorry. There's 2 films on Blackboard in the PowerPoint of personality disorders. One is Back from the Edge, talks about borderline personality disorder. And the other is what it's like to live with borderline personality disorders. So both of those films are really important, and they're told in terms of a person's experience with having borderline personality disorder. It's very enlightening, because I think we are disparaging, we don't appreciate people with borderline personality disorders. We're quick to judge them, quick to be upset with them. People can be very difficult to work with, but I think both those films will help you develop some empathy. So I will be asking you specifics about those 2 videos. Then the eating disorder, I mentioned Laura Hill, and I will also take some questions from that. There's another piece under personality disorders that I just want you to look at. And to me, it's real interesting, because I went to a conference on sociopath versus psychopath, in terms of personality disorder, and always use them interchangeably. But I think for you to just review what I've written, it's very quick, and it says read sociopath versus psychopath. So just be aware of that. I think, take you about 10 minutes to look at it and try to understand it and what the distinctions are, because there absolutely are some differences in terms of the 2 personality disorders, both of them being very upsetting and very difficult to treat, and certainly looking at psychopath in terms of their danger to society. So, all right, so good luck with listening to all this. I know it's a lot. It's been a lot for you over these past several weeks. I really appreciate you, self-motivating learners, and having to learn through a different medium, and how it's not so interactive. But again, I've wanted to capture these for you so that you can look at them anytime. You can review them again next year as you're going through some different issues in your practice, and as seniors, and in your nursing career. So I wanted these to be available to you. All right, so blessings. Bye.